Hello, this is Mark McClellan from the Duke Margolis Center for Health Policy. And on behalf of the Accountable Care Learning Collaborative with Duke, Levitt Partners, and WGU, I'd like to welcome all of you to this afternoon, at least on the East Coast, this afternoon's ACLC webinar on optimizing care coordination. We're going to talk about the methods and leading practices for care coordination from two organizations that have been at it for a while and are involved in some very interesting and effective efforts. Before we get to that, I have a little bit of housekeeping and then some introductory comments. So we go to the the housekeeping slide here. Just keep in mind that we'd like you to minimize the feedback and maximize the quality of the sound on this webinar. So please do make sure your phone is muted when you're not talking. You can use the phone mute. You can click on the microphone if you're logged in via the computer app, and just make sure that we don't have we don't hear from you when you don't have something to say. We are going to have hopefully some time for questions along the way. You can submit your questions or comments at any time using the GoToWebinar question box for those of you who are logged in online. And also, if you're not logged in online, we'll give you a chance to ask questions later on in the webinar as well. But if you are logged in, please send along questions, comments at any point. That enables us to incorporate them most effectively. And on to the next slide. We are going to cover, as I said, the main topic for today is presentations by WellSpan and DaVita Healthcare Partners on some of their leading efforts around care coordination. Briefly before that, I have a few important updates from the ACLC, and then again, we're hoping to have some time for questions and discussions towards the end of the webinar. On to the next slide. This is a big week coming up for the Accountable Care Learning Collaborative. Many of you have been deeply engaged, and I think all of you in the ACLC are aware of and contributing to our efforts around identifying the key competencies needed for success in reforming care and succeeding under new payment models, readiness for a value payment world. We are releasing the preliminary version of these core competencies next week. You should look in your email for the embargoed pre-publication copies of the papers, as well as the accompanying documents, press release, social media guides, and some other supporting materials. Should also let you know that this is being done in coordination with an effort underway by the National Academy of Medicine. The NAM has identified supporting better capabilities for succeeding in value-based payment as a key policy priority for next year, for the next administration, the next Congress. Our report is going to be out next week, but look in the following week, the next Monday, for release of a set of materials from the National Academy of Medicine. This is going to include a JAMA publication, one of their online first priority publications on vital directions for health and healthcare that is focusing on core competencies needed and how they can be best advanced as part of the challenging but very important journey of getting to much more effective high-value care in this country. We'll have more information and links to those materials as they become available in the following week, but we are very pleased that we've got this coordinated opportunity to both get out the work that the ACLC has been focused on and to get the reinforcement from the National Academy of Medicine's recommendations related to supporting the development of better competencies for value-based payment as a key policy priority. This is also going to be reinforced by collaborative work that we've begun with a range of other organizations around the country, the Healthcare Transformation Task Force, provider groups like Premier that have been involved in advancing accountable care, groups like CAPG that also have useful resources available to support this goal. This really is a call to action, a call for collaborative action to advance the capabilities of healthcare organizations. It's a critical factor, as you all know, in the success of payment reform and the success in ultimately getting to higher value healthcare. So it's a very important couple of weeks coming up, and look for a lot more materials from us related to that. On to the next slide. Upcoming, we have a number of events. I want to first mention one that was in the recent past. On Wednesday, David Muhlstein from Levitt Partners led a webinar summarizing and providing some critical insights into the latest results from the Medicare ACO program, the Medicare Shared Savings Program. As you all may know, CMS released a summary of their 2015 results very recently. We, with David's leadership, have taken that data and those results and compiled some very important lessons from the experience to date. That webinar is available online at the ACLC website, and along with some supporting slides, other summary materials. We also had a paper that covered these results released by the Health Affairs blog online a week ago as well. So a lot of resources to help make sure you're up to date on what we know about the results in the Medicare ACO program so far. Some other events coming up. September 28th, the ACLC database orientation. As I mentioned, we're releasing a range of resources related to core competencies for success in value-based payments and data related to that. So look for some supporting information and orientation to that at our webinar on the 28th. Then our next major hour-long webinar related to these core competencies will be on October 13th, Discovering a Population Health Approach, Pursuit and Execution, again with a very practical focus. And then we hope to see all, or at least many of you, in person at our next ACLC member meeting in Washington on October 18th and 19th. This will be an important opportunity both to get an update on what is happening in the national policy environment related to payment reform. It's a very active time with, as I just mentioned, further reports from what's going on in the Medicare ACO program, but also new developments and Medicare's bundled payment programs and MACRA. We'll be having participation from CMS in this meeting, as well as private sector leaders from around the country. The meeting will also be an opportunity to go into more depth about building on the competency work that we've developed, about how to move forward on that journey to developing the capabilities needed to succeed in increasingly advanced and sophisticated payment reforms, and lots of opportunities for interaction with other healthcare organizations like yours that are working through these issues right now. So that's coming up on October 18th and 19th, and more information available on the website and from the ACLC staff if you have any questions or comments about those upcoming meetings. And then finally, I wanted to mention our next work group meeting. So these reflect the major the major competency areas. Just because we have these competency reports out next week doesn't mean we're done. Again, the focus is on building out these resources, linking them to other activities going on around the country, and helping to move forward more quickly on the journey to enhance abilities and greater success in all of these key dimensions of payment and healthcare delivery reform. So you see the schedule there. We hope, we really appreciate the effort that many of you are putting into sharing these resources, learning from each other, and making it available, and we hope you'll continue to do that. Just a few more details about the ACLC member meeting coming up on the 18th and 19th. I went through some of these major components of the meeting before. So we'll include a nice in-person meeting for the work groups. We found that to be extremely helpful for really exchanging ideas, both to strengthen the tools and reports that we are producing, but also to give you all a chance to really interact with each other around how to solve these practical problems and make progress. So at that meeting, we'll be reviewing competencies, incorporating some of the feedback that we're getting from our public release and collaboration with other organizations and planning for next steps. And then I already went through some of the key priority activities for the full ACLC meeting on the 19th, including policy updates, review of what's going on in the accountable care landscape today and what is coming, both post-election and based on our assessment of the latest trends in payment and healthcare delivery. Tim Granger will be joining us from CMS. He's one of the deputy directors who oversees a lot of the innovative payment reform models that go beyond ACOs, but that are increasingly going to interact with ACOs. Some of the episode-related payments, some of the new steps that CMS is taking related to payment reforms affecting drugs and devices. So we'll have a very good discussion with him, as well as some opportunities to exchange ideas and hear from some national leaders who have been successful in some of these key competency areas. So we've got registration links available on the ACLC website. They'll be in the newsletters that you get from us every Tuesday, and again, we hope to see you there. Just moving on to the next slide. We are going to cover today a very important area of competency for success in value-based payment and high-value care delivery. We have two sets of presenters. First, from WellSpan, we'll be hearing from Dr. Charles Chodroff, who's Senior Vice President, Population Health and Chief Clinical Officer at WellSpan, as well as Ann Kunkel, who is the Director for Case Management, which is, as you all know, critical to effective care coordination. Their presentation on WellSpan's experience and their approach to developing capabilities in the area of care coordination is going to come first. And then after we've heard from them, we're very pleased to have a second presentation today from DaVita Healthcare Partners. The DaVita Healthcare Partners leaders who are with us include John Prassas, the Vice President for Provider and Payer Contracting, and Nate Aumock, who's the Director for National Contracting and Growth. And they're going to talk about DaVita's experience in this area, and again, some practical focus on how to coordinate care effectively in a way that helps lead to success with capitation as well as other value-based payment approaches. So with that, I'd like to turn this over to our first set of presenters. After the presentation, Scott Hamler will be moderating the further presentations and the discussion. We're looking forward to hearing from our speakers now. So let me turn to you all. Charles, Ann, if you're take your phones off mute, great. I can hear you just fine, Charles. Thank you.
Okay. Good afternoon, everyone. I'm Charles Chodroff, Senior Vice President of Population Health at WellSpan Health. I'm joined by Ann Kunkel. I'll be walking through the slides with you, and then in the question and answer period, Ann will be handling most of that. This is really an overview of a 4-year journey that Ann and I undertook to transform what had been siloed case management efforts in various areas of our health system into a unified model of case management. Ann and I developed the strategy along with several other leaders at WellSpan, and Ann has really been the chief implementer. So, you know, of course, when there are questions, it'll be Ann that'll really be the most knowledgeable person on answering them. You can go to the next slide. We begin with our mission statement, not just because it states what we aspire to do and what we're aiming to do, but it really talks a lot about how we do it. These 16 words mission statement begins with 3 critical words for us: working as one. That's something that is really very important to us in a highly matrixed organization that emphasizes team-based care at its heart. And as you'll see, our model was meant to weave case management across many different areas of our health system into one unified function. And that our health system now spans multiple distinct communities that each have their own local healthcare delivery systems. And we wanted a consistent model in the various communities we serve. Next slide. We began, WellSpan began from a hospital roots, but today when we talk about WellSpan, we emphasize our physicians and our provider network, because I often will say that we are a large medical group and integrated health physician network that happens to have hospitals. And it really emphasizes our perspective on keeping people out of hospitals whenever possible. There are 5 acute care hospitals in 4 distinct communities. We also have other aspects of the care delivery continuum. And again, our challenge that we began in 2012 was how to take disparate case management approaches that were beginning to evolve as our medical group began implementing medical homes, our hospitals that had very traditional case management programs. And in addition, we have a PPO health plan that administers health benefits for our own employees and a number of other local self-insured employers, and it had a case management function. That entity we now call WellSpan Population Health Services, and it's our internal engine for population health management. And as we have been shifting away from PPO business to actually value-based contracts with commercial payers. Next slide. We currently have a number of populations that we consider at risk, and we are at risk for a combination of financial and clinical outcomes. These span Medicare Advantage populations in a relationship with Geisinger, and that is a partial capitation arrangement, our own employee health plan that we fully administer, including pharmacy benefit management, and that we call WellSpan Plus. That has about 20,000 members. We partner with Aetna for commercial insured, and we are also a Track 1 participant in the Medicare Shared Savings Program. We also have a unique program that we call Healthy Community Network. There are approximately 3,000 uninsured individuals in our communities who, despite ACA, for one reason or another, need access to care and have no financial resources to get it. And we serve as a bridge for that population to get them enrolled in Medicaid whenever possible, but we manage them as a risk population because, in essence, the care we provide is at our full risk. We have embarked on a patient-centered medical neighborhood strategy, and that is our risk networks care management model. So again, the case management model that we have put in place supports that medical neighborhood strategy. Now, of course, in addition, we still have our 5 hospitals and over 60,000 admissions each year, and we must continue to do a substantial amount of what I'd call traditional case management activities with utilization management, getting payer approvals, and then, of course, our hospitals are all at risk through value-based purchasing and other forms of value-based payment programs with commercial and governmental payers. So that is another aspect of the case management activities that we continue. And we see ourselves on a glide path moving rapidly over what we think will be the next 3 to 4 years from predominantly fee-for-service to value-based model. Those populations on the top of this slide account for a little over 70,000 covered lives right now, but that is still probably less than 20% of overall business. Next slide. So a few key points here that we've lived with is that we really need to engage our consumers in episodes of care in our hospitals. At the same time, we want to use our medical group practices for longitudinal management of chronic illness and wellness. We want everyone on the care management team to be thinking about safety as patients progress along their continuum of care. And we are embrace the concepts of lean. And as I mentioned, all of this is really dependent upon transforming our business model. So we are slowly but deliberately engaging in contracts with payers for full risk. Medicare is the only shared savings arrangement we have. All the other models, we have full upside and downside risk. Along the way, of course, we are implementing lots of tools. We won't go into those today, such as risk stratification tools and claims analytics. We are now looking at investing in software that will provide us an analysis of our populations with social determinants of health that will be very useful information to our case management teams. Next slide. So one of our key principles that we established 4 years ago is we want our patient-centered medical homes to be the central locus of care coordination. Whenever possible, with any population that we work with a payer on, we try to strongly communicate to the beneficiaries the importance of establishing a relationship with a medical home. And a couple of slides on from now, I'm going to go into the actual model, but you'll see that it's a tight linkage into the patient-centered medical home. We are firm believers in the primacy of primary care in coordinating individuals' care. But again, the model links across the continuum, and at the heart of the model is what we call the care coordination team. And what we have done is take traditional hospital-based nurse case managers and social workers and link them to medical homes rather than to hospital units. So that was a very disruptive change to our workforce when hospital units no longer have dedicated social workers and case managers, but instead our medical homes have a care coordination team that is centered on their patient population. We really turned the pyramid upside down here. At the same time, we're trying to transform our inpatient medical surgical units into what we call accountable care units. And this requires that we have resources for care progression at the nursing unit level. Go on to the next slide. I'm not going to go into detail, but as we began this work, we established a number of principles that we shared with the case managers, social workers, and to create this unified team across our health system. And I'm assuming these slides will be made available to everyone. So again, I won't go into them in detail, but they really emphasize the importance of the team in creating the linkage with the medical home and to promote continuous ongoing support. Next slide. This is the slide I'd like to spend most of the time on because it really explains our model. So at the heart of our case management model is something we call the care coordination team. And that team is linked with our patients. Now the top half of the slide that's in blue is meant to represent the inpatient world. The bottom half of the slide represents the community or outpatient world. Let's start in the bottom, out in the practices on the bottom right-hand side. In each of our medical homes, we have at least one, and now we're placing, in some cases, 2 health coaches. These might be licensed practical nurses. They are general. I'm not aware of any of the more than 36 sites where we have health coaches have actually registered nurses. They receive special training on chronic care management. They are well-versed in the chronic care model, and they are integral to the function of the medical home. That is, their sole job is to track individuals who are in our risk populations and to coordinate their care. they report up to our medical group, but they're linked in a matrix fashion to the entire care coordination team. Now, going over to the bottom left-hand side, we have population health case managers. These are the former case managers from our health plan. They sit in a central office, and their task is to coordinate out-of-area care for patients in our risk populations who need services not available at WellSpan. And they also are using predictive analytics software to cull through the clinical and claims data of our population to surface up impactable patients. They will find these patients and then be in touch with the health coach to say, here are your patients. Now, these population health case managers are also assigned to specific medical homes. However, unlike the health coach, which is just at one medical home, a population health case manager will have multiple medical homes that they're servicing. Now, out also in the community, we have a number of nurses. These are all of these are registered nurses who work in our service lines who are supporting special populations. And we call them disease navigators. They're nurse navigators in oncology, COPD, heart failure, our LVAD program, in our neurology program, and they have specialized expertise and are available to help with particular patients, and they are seen as part of the team as well. Now, those workers that are who are physically housed in our hospitals are in the top half of the slide, but again, they are fully part of the team. And they include social workers and case managers. They follow the patients of the particular medical home that they are assigned to as the hospital, and they follow them into the post-acute space as well, but they tend to spend most of their time in the hospital. Now, the case manager is also doing payer coordination to make sure we get approvals on fee-for-service patients, and even in our relationships with Geisinger and Aetna, we still have to get approvals for them for post-acute needs. The way this team coordinates is through daily telephonic huddles, and every morning, Monday through Friday, they have a 15 to 30-minute huddle where they go over all the hospitalized patients, recently discharged patients, and patients who are in the community setting who might have social needs that would require the assistance of the social worker. Very early in the model, we got incredible pushback, as you can imagine, from our hospitals, particularly nursing units that were specialized nursing units, who felt that we had abandoned them and that they weren't receiving support in care progression. So we've added another position called an outcome coordinator, and these are unit-based members, and they're the only member of the team that's not linked to the medical home, but they are part of our care management department, and they're well aware of the care coordination team. So this is really the heart of our model, and I imagine this is where you have a lot of questions about whether or not it's working. We have seen a drop in our readmission rate, and we've seen a faster drop in those practices for whom we are providing tight medical home support. Our hospitals predominantly admit patients from our own employed practices and the practices of those independent physicians who are in our risk network. But there are some patients who come in who are not part of that model, and they tend to have higher readmission rates. We've proven that. So we think the model works, but it's still a model in evolution, as what we're really trying to do is really impact the ambulatory sensitive conditions. So the next slide just summarizes the journey that we've been on. Again, this has been an adaptive change process. It's been very disruptive, but we're now starting to get traction, and There's a lot of esprit de corps now that's been built up between our medical homes and our inpatient case managers and what was formerly our health plan case managers. And I think the organization is now beginning to understand that this new perspective was really necessary as we shift from a value-based world from a fee-for-service world to our value-based world. So I think I'll stop there, and I believe that we're going to go on to the next presentation, and then we'll be available to take questions afterward.
Charles, thank you so much. This is Scott Hammer. We really appreciate your insight and sharing with us. We had one question that came through that might be good to approach right now, and this person asks, I would like to hear how you are measuring the impact of your care management interventional strategies. Could you and Ann maybe talk about that a little bit?
This is Ann. Hi. Some of the ways in which we are measuring that is we are tracking avoidable hospitalizations. That's a measurement that we look at across our system in terms of the ARC definitions of avoidable hospitalizations. Readmission rates and overall utilization rates are another area that we continue to track in terms of outcomes measures. Besides the outcomes measures, we have some process measures that we look to do. So how well are we utilizing our risk analytics tool? How many patients have we been able to touch and develop action plans in terms of each patient population in our practices is one of the areas that we focus on. That's a lot of the work that we do. Supporting the structure of this, we do a care coordination team collaborative, and in that's where we monitor and share with the team our metrics, where we identify performance improvement areas, and then share techniques and learning opportunities, so motivational interviewing and those kind of curriculum are built out of that. In our accountable care units, we're tracking length of stay, readmission rates, and the connection to patient satisfaction in terms of our population. Our foundation for the accountable care units was based on work that the Society for Hospitalists have done, particularly at Emory, and we adapted their model to incorporate nurse manager, medical director, which is one of our hospitalists, and then the outcomes coordinator role for that unit.
Ann, thank you so much. That is very helpful to understand. I think at this time we'll plan to move ahead to DaVita Healthcare Partners, and I'll turn the time over to John and to Nate. John, the stage is yours.
Thank you. Appreciate it. So what I'd like to kind of talk about is where the last presentation had a lot of clinical feel to it. Nate and I are really going to be talking about the business side of building up our accountable health team and the connection back to what client demands are evolving into, and in connection with that, the product portfolio that we see emerging in the marketplace. And I think one of the interesting things that was brought up in the last conversation was this buildup of resources and infrastructure to support population health and care coordination, and then the comments around moving from a fee-for-service model to a value model and the evolving reimbursement structures to support that infrastructure and resources. I think our conversation will be from maybe a different lens, given most of our businesses in the mature market, where we're actually seeing the opposite dynamic of an entrenched HMO market where we historically had been funded, and a movement towards more PPO-based consumerism products that actually makes it a challenge to continue to fund our infrastructure and get the right pricing and reimbursement models to support a population health program. So I think it'd be interesting as we get into the Q&A session about these kind of two directions that we see healthcare going in. In some markets, we see that move from truly a PPO fee-for-service into more value-based, and in other markets, like the challenge we're seeing is this movement away from some of these kind of entrenched HMO products and the stress it puts on our systems as we try to maintain these triple aim models. So, and then I think the other kind of big theme that I would ask everyone to be looking for in our presentation is we really do feel like under a learning collaborative, what we're about to present is a challenge and a problem. We obviously view it as an opportunity too, but again, would welcome comments and input as we get to Q&A about how this dynamic is playing out for us, this challenge that we want to talk about. My background, I've been on the payer side, the provider side for 20 years. I've been with DaVita for a year. I'm focused on contracting and then supporting our new business development. I'll speak for Nate. Nate's been with the company for close to 3 years, and he's been entrenched in our national team as far as contracting and has branched into our growth and new product development, as well as really driving our infrastructure to support new products. Neither of us have clinical backgrounds, and we're both looking at this from a business perspective. The slide that's currently up is really our core principles from our medical group. I think it's important to talk about DaVita as a company. We are really split into 2 divisions. Our primary division, which really kind of built the company, is kidney care, with dialysis being the main revenue driver of that business. That kidney care division of DaVita is a global enterprise. It's I believe we're in 10 different countries around the world, and have a large footprint, obviously, in the U.S. About 5 years ago, that kidney care division of our company decided to diversify and bought a medical group called Healthcare Partners, which was a well-entrenched Southern California medical group with a big presence in Nevada, in Southern Nevada and Las Vegas, and also had a presence in Northern Florida. After buying that asset and creating this division of our medical group, we entered New Mexico, Colorado, recently entered the Seattle market with an acquisition of the Everett Clinic, which was done in March of this year. So if you could go to the next slide, you can kind of see our footprint. So this again is just a medical group division, and I think what makes our company unique, as we talk through the rest of the slide deck, is we have markets like Southern California, which have decades of entrenched HMO products with very well-organized large medical groups. We have a huge Kaiser presence, so the marketplace does have a certain maturity and standard that I think Kaiser does a very good job of setting in the markets they compete in. And then we've got markets like Philadelphia, where we're in a joint venture, and it's a traditional PPO market, and we're there working with the health plan to build up some of their managed care capabilities. And then we have markets like Colorado, where we have a joint venture with the hospital system to build out a managed care capability. So we really don't have a single as far as how we look at medical group execution and population health. We embrace joint ventures as much as we have a model around doing acquisitions and having sole ownership in markets. As you can see from the bottom part, we have a very large population as far as patients. We're going to be close to 2 million members at the end of this year. A good bulk of that is within risk contracts. We have large employed physician base, and then we obviously have 13,000 affiliated physicians that we contract with across our markets. Our traditional model is to develop a multi-specialty employed group practice. We then contract out with affiliates for additional services and geographic coverage. And then we build out through a full delivery system of hospitals and ancillary. And then we have a sole solution for taking on additional risk up to a global risk environment with health plans. Next slide, please. So I think this slide kind of shows you where we're at from a revenue model. I think where the last conversation under WellSpan was about this movement towards taking more risk and having a revenue source that moves away from fee-for-service. Given our large population in California and Nevada, where we have entrenched HMOs, not only in the Medicare business, but also in the commercial business, our revenue model is very heavily towards capitation. As we'll talk through on some of these other slides, I mean, our infrastructure that we've built as a medical group has been well funded by this capitation model because it's obviously an opportunity for us to get a return on investment for these resources that we built. Fee-for-service is a part of our business, but it historically it simply has been an afterthought. It hasn't really been a P&L dynamic for us. It's been just part of our portfolio. We really run our business from a global capitation lens. Next slide, please. So this is kind of our model, and I think it's worth a few minutes to talk about. So so as I was saying, we have an employed group, multi-specialty model. We then contract out to build out their affiliate network through an IPA model. We then, in markets, identify a hospital partnership, bring in a hospitalist group to that hospital, and create a value model where we essentially make commitments to the hospital that we will reduce their cost structure through length of stay and efficiencies. And if we're successful, we participate in some of the savings. So it really is a cost-to-charge ratio type of discussion with the hospital where we basically create a reimbursement model and work out a incentive model that basically states that if we can get their cost-to-charge ratio down versus the reimbursement that we're paying them, we get to participate in that savings opportunity. And the way we do it, so we build a aligned reimbursement model, and then we use this hierarchy of programs to really support the community around that hospital. So we'll have our group practice employed model locations around that hospital. We'll contract out the affiliate network. We will develop a comprehensive care center that would be in the proximity of the hospital so that when the discharge planning is occurring and the patient's being discharged, we actually have a dedicated center to reintroduce that inpatient patient back out to the outpatient setting. In most of our big partnership hospitals, we actually have a high acuity urgent care that's on the campus to actually help them triage the right type of emergency services so that we can be a partner in that dynamic. And then we build in our home programs and our population health care management and other disease programs as support as the patient goes back to their home. So we actually, not unlike if you want to look at a Kaiser model, when we partner with a hospital, we make tangible investments into the facility, the surrounding area, and we add this outpatient comprehensive infrastructure to deal with some urgent and emergent patients, the discharge planning dynamic of getting the patient reacclimated out to the community, and then we have the physician resources in that area. We do not take equity, and we're not in any type of ownership dynamic with any of these hospitals. It's purely based upon a commitment around a partnership that we make these investments in the community around them and build up a integrated delivery model with them. Next slide, please. So as I was saying, California and Nevada are kind of our foundational markets. California, from a revenue, membership, profitability perspective, is about 50% of our company. Nevada it's obviously a smaller market, especially given that we're just in the Las Vegas metro area, but we are well entrenched in that marketplace with a similar mature model like we have in California. Other markets are still in development mode. So Florida, as all of you would know, is a mature market we focus more on Medicare than we do commercial in that market. So I would say our Medicare offerings in Florida are very mature, but we haven't really developed all of our muscles on the commercial side. And then in other markets like New Mexico, Colorado, and Washington, which frankly are some of our more recent acquisitions over the last 6 months to 2 years, those markets are in different levels of development to get to a Nevada, California type of global model. Next slide, please. So I kind of want to jump over to the product piece and kind of really what the purpose of this conversation is about. So we were pretty fortunate that in markets like California, Nevada, and Florida, that we had a big block of Medicare business, and the plans that we worked with were embracing a global risk model. So we basically had a big cash flow revenue source through a global capitated Medicare foundation. California, which is our biggest market, also had a preference for commercial HMO products, and we had a large block of commercial HMO. And so we were pretty lucky to allow PPO to be a small part of our business in some of these key markets. And a few years back, we started participating in some of these commercial ACO products that were PPO-based, and we started building out a team to support kind of this unique dynamic of a member that's attributed versus assigned, and a member that had freedom to not always follow all of the rules, and a patient that could be non-compliant and hard to track down. And so we really kind of did what you'll see in a lot of slide decks from a lot of different companies. We built a patient engagement model. We built a provider engagement model. We started building up an infrastructure, and we had a small team of folks that were around this ACO organization, not only to support these products, but also support our CMS ACO participation. And to some extent, the medical directors were part-time. They had other duties within the company. But these products did have some revenue sources through care fees. And as we were performing well, we were getting some shared savings. But there was very little downside risk. And for the most part, we looked at these products as a great opportunity to learn how to expand our existing population health assets into new product offerings that were more PPO-based. And we were fortunate in that our two biggest ones that we launched right off the bat, which was Cigna and Anthem, we were actually getting pretty substantial shared savings because of our model, and some of the carryover from our HMO model gave us a head start in some of the work on the PPO business. Okay, we can jump to the next slide. So this is really the kind of the crux of the discussion today. So we had this core foundation of legacy products that were HMO-based, where we had a global model with a pretty predictable cash flow. We were establishing some small pockets of ACOs for PPO. You could argue some of them were experimenting on how we tweak our model to work for PPO. Our initial results were positive, so we were actually getting shared savings, which supported that infrastructure. And it seemed like things were moving well. What we saw in the last 2 years, though, is a concern. So our challenge now is we've seen a whole new slate of ACO products, narrow network products, new types of tiered networks. And in some of our key markets, Southern California and Nevada, we do see this emergence happening up in the Pacific Northwest in Seattle. We're having employers that are coming out demanding multi-year price guarantees. And the ACOs that we're beginning to work with are agreeing to those type of demands. And we're seeing not only initial pricing, our foundational cost structures under these ACOs being a large concession for participation, but we're also seeing commitments that require us to be long-term participants under very aggressive trend guarantees. And all of that, I think, is just a natural part of the business. But when this is happening under a non-HMO product, where we also are taking the risk of non-compliance and attribution dynamics, we're seeing a lot of challenges. And you know, on this slide, as you look at it, we basically with every major national carrier, which I know there's not a large list, but the three that we work with, all of them have come to us with some either national solution on an ACO or a local regional solution, and we're in the process of working with each of those around a new product. But we also are seeing the Blues plans in all of our major markets coming out with very aggressive, oftentimes less than the cost of living type of increases with upfront reductions of close to 10 to 15%. In one case, we had a product that we were essentially pushed into that was almost close to a 20% reduction from our historical pricing dynamics. All of these are hitting going into 2017, 2018, and we are seeing large municipalities buying these products. We're seeing large employers that, after they're seeing the success of some of these being launched, also pushing for it. So I think our big challenge, and when we get to the questions I would really like to hear folks talk about, is these products are adding to existing products. In all cases, these ACOs are looking for long-term solutions, so these aren't 1 or 2 year deals that we can have decision points in getting out of. The upfront commitments are compression and pricing, and the long-term commitment in some cases is actually zero trends over multiple period of time. And we do think that this is the reality of 2018, and we do think that more large, sophisticated customers are going to be pushing for these type of expectations. And our dynamic is we have this pretty well entrenched, not only asset base of urgent cares and care coordination centers and programs built around population health. We are, in addition, adding staff and teams to support this PPO launch with the attribution dynamics that we do think require additional staffing. And the products of the future that we have to support have lower funding, tighter commitments, and frankly, are being added to an existing portfolio of products. And now we have close to a dozen different relationships with a handful of carriers. All of them have different moving pieces with membership migrating between each of these. So, as I turn this over to Nate, if you want to jump to the next slide, you can.
Yeah.
Turn this over to Nate. Oh, I'm sorry, Nate. Let me just. So, as I turn this over to Nate, and Nate will kind of go over our ACO model, which is really that team that's focused around supporting these EPO, PPO, ACO type models that we view as the future. I guess the point I'd like to leave you with is we are grappling with how do we build and fund the infrastructure that we think we need for the triple aim, which we've been very successful on in our core HMO, as the marketplace evolves and the products don't necessarily fund or support this commitment of infrastructure that we have. So Nate will go over kind of what our team looks like, how that team is growing, and then I would leave it as a question for the audience, and one that we are constantly getting our head around is as these products and consumers demand new solutions, how do we fund these infrastructure that's needed, and how do we stay flexible so that we can meet the market's needs?
John, before we get to Nate, a question came through that maybe you and Nate could talk about. It says, what are the RCC ratios that you are seeing? It goes on to say, I assume the costs are coming from a charge master and not time-derived activity-based costing. What is the effect of the reductions in utilization on revenue and margin? Touch upon that at all?
I guess I didn't catch the second half of that question.
So the second half is what is the effect of the reductions in utilization on revenue and margin?
Is this a question from a hospital's perspective? Like, how does this impact their revenue and margin?
Well, I think let me take a crack, John. Then I think from our perspective, it doesn't have much impact on us because we're talking about reduced utilization at the hospital. We don't own hospitals, so for us as a medical group, I mean, we're just incentivizing PCP visitations and trying to drive people to that person that can help them navigate the system. So I don't know if we have a perspective on the impact on the hospitals. When you blend it into a broader book of business, I'd also say it's not material in the relationships we really foster at this point in time.
Nate, that makes sense. Thanks.
So I know we're running out of time, guys. Let me go quickly through a few things and we'll have to get into the questions. I'm happy to be here and thanks for having me today. Look, our model of care goal is also about being patient-centered. Similar to what we heard from WellSpan, I think that is a key piece of what we do. Let me keep going. Can we go to the next slide, please? So what are we trying to measure? What are some things we're working on? All-cause readmits. A lot of this stuff is going to look very familiar. Staying out of the emergency room. Transitions of care is a key lever that we've been successful with in the HMO that we work to apply to these populations as well. And in the end, really, what can we do to empower our patients to give them the resources to be engaged and to manage the chronic conditions where they have them or stay healthy where they don't? Next slide, please. So practically, what does this mean? So we're coming from a place where we're focused on the HMO. So a member is aligned with a clinic. They're very integrated into that center. In this ACO population, we obviously are trying to build that connection, and similar to our last speakers we're talking about, but they don't have to be as anchored in some of these attribution models. So what we're trying to do is there's a couple of things that we're laying here when these members are coming to visit. Focusing on engagement with the provider, acknowledging that they're part of the ACO, so reminding them and telling them, because in some cases they don't know, right, in these attributed models, whether or not they're participating in these programs. Providing access, providing recommendations on the right high-quality specialists and sites of care to see. Also, you'll note one thing here on the quality line. We use one of the tools we've developed as part of our HMO, which is called the Patient Intervention Report. It kind of gives an overview of what quality metrics are of most importance to keep this patient healthy, and how have we done on them? Are we up to date on doing the right screening? So these types of tools we apply to the HMO membership, we're also applying in the same way because patients need the same types of things in these EPO and ACO products as well. Can you go to the next slide, please? And then, as I mentioned, transition of care is one of the key pieces of this, I think, for the members and patients that do end up needing to go to the hospital. How do we make sure they're getting the right care at the right place at the right time? And so we have this kind of checklist, which is one of the things that our ACO team has kind of published as kind of their thought process. So in terms of what are the things we do, helping them have someone to navigate with, to look for conditions that require maybe a high-risk program or a higher touch follow-up type care, medication management and reconciliation, and all these other things. And this is some of the stuff that our dedicated team helps to do for the ACO members, to provide these types of services and try to connect them back into the PCP and the other avenues of care delivery that in these ACO models you don't always have connection to. So trying to broker those connections when they're not enforced like they are in the HMO environment. Next slide, please. And just the last slide I wanted to speak to is talking about our commitment to this. So this is just number of folks, number of teammates that we have that are directly supporting our ACO and kind of new product efforts. And we have a good team today, but we're looking to grow by 40% or so in the next couple of years, just as we expand both the amount of participation we have in these types of programs, the number of programs, but also as we increase our focus and try to think what else can we apply from our kind of core competency of Medicare Advantage, HMO managed care. How do we make that accessible to broader populations, particularly as some of the trends John spoke to, what are the commercial employers looking for as they move to more high deductible plans? We're seeing some decline in HMO enrollment, so how do we participate and continue to provide high quality care for those patients that are no longer able to see us in an HMO? Yeah, and one thing we glossed over, but it's the last bullet point on that previous page, is that this is the dedicated team. We have an enormous team of resources and support infrastructure around this that is focused on our HMO patient base, but that also plugs in targeted ways for ACO patients. So things like the disease management programs, high-risk clinics and management programs, and these types of things that also can support. So we come at it from a very different place than many other parts of the country in California, coming from that HMO capitated delegated environment. It's really a challenge of not how do we get to value-based care, but how do we apply value-based care in something that's closer to a fee-for-service environment. So it's an interesting way to think about it, especially as I think about how we do the opposite in our other markets like New Mexico and Colorado. They're on a journey maybe more similar to WellSpan. How do we move from fee-for-service into value-based? So one of the fun challenges that we get to tackle and deal with every day.
And I would just leave you with that one comment. I think for a learning collaborative, I think it's just a good question. Is what the unique lens that we're seeing is we've got markets, as Nate was saying, of Colorado and New Mexico, maybe even through Washington and that, where they're looking to move on this pathway to a more structured product with additional risk to help support funding their programs. And then in a core market like California, which is at a maturity level that's pretty unique in the country, we're actually seeing a counter trend to that, where there's this movement away from HMOs into these more fee-for-service, value-based products. And so I guess for the audience on the phone that's in multiple markets around the country, if you're making investments within your organization on the belief that you're going to move on this journey to a global risk relationship and that you'll have that funding and shared savings to pay for all this infrastructure, I think it's worth for the dialogue of what's happening in California and this migration away from HMO, and then this essentially different funding models and the different demands of clients around price being a big part of the discussion, and not just the population health infrastructure. It may make you second guess on some of your financial models around how do you get that return on investment for the population health commitments that you're making today, if what we're seeing in California creates some kind of middle ground for the nation, and that we need to look at how exactly do we fund and get paid for population health if the products don't continue on the path to a global risk model. And that to me is just the real message out there that I think everyone should at least spend a few minutes thinking about.
John and Nate, thank you so much. We really appreciate your time and sharing this the compelling work that you're doing at DaVita Healthcare Partners, and we're certainly impressed with both WellSpan and DaVita and the great work that you're doing in your markets to further accountable care, to improve care coordination, and those functions of making healthcare better within your communities. We've learned a lot today. It's been a rich and compelling session. Thank you to our presenters for their insights and perspectives today. We're thankful that they were able to join us. An audio recording of this conference call will be made available, and will be included in our weekly news summary. The next webinar is Wednesday, September 28th, and we will do an overview of the ACO database that ACLC members have access to. If you have any questions about the ACLC or follow-up questions from this webinar, please email members@accountablecarelc.org, and we'll be happy to address your questions. Thank you for joining us, and we hope that you found this presentation to be worthwhile. Have a nice day. Bye-bye.